Overcomers, and welcome to this episode of Connect Over Coffee. I'm Runsi, the founder of Ovarcom, and today we are joined by a very special and esteemed guest, Dr. Priya Bhosale. So Dr. Bhosale is a professor and director of research of diagnostic imaging at MD Anderson Cancer Center, and she has authored and co-authored over 130 peer-reviewed articles and over 100 abstracts in scientific and educational exhibits at national as well as international conferences on the topics of body imaging in gynecologic as well as pancreatic malignancies. Most importantly, Dr. Bhosale is a founding board member of Ovarcom. So as you can imagine, we have a lot to chat with Dr. Bhosale today about everything radiology and imaging as it relates to ovarian cancer. So grab your favorite coffee. I have mine, and let's connect over coffee with Dr. Priya Bhosale. And then if you have any questions as you go along, please type in the comment sections below and we will get it addressed post the discussion. So with that, a huge welcome to you, welcome back to you, Dr. Bhosale, to this episode of Connect Over Coffee. Always an honor to have you with us.
Thank you, Runsi. Thank you for inviting me to this episode of Ovarcom, Connect Over Coffee.
Yes.
I'm excited to be here.
Thank you. So, I have several questions for you from an imaging standpoint, but before we get started with that, can you just tell us what is radiology and from an imaging standpoint, what are the radiographic signals and signs of ovarian cancer, and what is the best form of imaging when it comes to ovarian cancer diagnosis?
So currently, imaging consists of different modalities. We have ultrasound, contrast-enhanced CT scans, and non-contrast-enhanced CT scans. We also use PET-CT, which includes glucose-tagged particles, which are taken up by cancer cells, and then we use MRI. Currently, the novel modalities are PET-MR, and the research modalities could be hyperpolarized carbon. And there are several pharmaceuticals which have been used in assessing ovarian cancer in the past. Some of them have showed promise and some of them have not been used any further because they could not detect ovarian cancer. One of the agent was PSMA PET. And it did show a little promise. It did show some cancer in some patients, but it was not fully diagnostic. So we have a myriad of imaging modalities available. And currently the most useful modality, or the first used modality for assessing ovarian cancer, is ultrasound, because it's available everywhere, every corner of the world. And it is very easy to perform and can be done in an office setting. Takes about a few minutes to do it, and it does not cause pain when it is used transabdominally, but you also can do transvaginal ultrasounds. Those are more diagnostic than the transabdominal ultrasounds. And the only problem with the ultrasound is it's operator dependent. The person who is operating the ultrasound machine should be really knowledgeable about the machine and how to image those patients. I mean, it cannot be used by anybody to diagnose an ovarian cancer. So that's pretty important. I mean, when we do large cohort studies, we need to have an experienced sonographer looking at your ovaries to make sure that they have detected the cancer or evaluated the ovaries very well.
That makes sense. Thank you so much. And so, in the life cycle of ovarian cancer treatment, right, and also in survivorship, how often and at what junctures do you think is radiology utilized and to determine treatment planning? And so what I'm trying to understand or ask here is, radiology, in my opinion, has a very important role when it comes to the ovarian cancer, not just in the diagnosis phase, but also through treatment to understand how the cancer may or may not be progressing or responding to treatment, et cetera. So how do you think in this life cycle, at what junctures is radiology utilized? And then how is planning of the treatment of a particular patient then determined?
So when a patient goes to a clinician's office and then they feel a pelvic mass, they usually order an ultrasound. Now that could be related to different causes. It could be a cervical mass, a uterine mass, or it could be an ovarian mass, and this can be only detected via imaging. Then the first and foremost step or the study which we use is ultrasound. And as I said, the sonographer should be experienced to know what they are looking at. And once we diagnose a mass in the ovaries, usually the patient will go see an oncologist. I would prefer sending a patient to a cancer center rather than a general oncologist. And then the oncologist, the surgical oncologist, or the clinical oncologist will order a contrast-enhanced CT scan. At most institutions where contrast is not available, or maybe they have a different protocol to do these studies, if the patient goes to an ER, gets a CT, they do not get intravenous contrast. Now, intravenous contrast is really, really important to look at the characteristics of the ovaries and if there are any ovarian masses. So at MD Anderson, what we do is we do triple contrast imaging studies where we give oral contrast, we give rectal contrast, and we also give intravenous contrast. The rectal contrast is really important to look at peritoneal disease, implants or tumors which are involving the bowel loops in the pelvis, because without contrast, the bowel loops stick to each other without the rectal contrast, and without the oral contrast. And it's very difficult to discern the implants from bowel loops. And so this really helps us, and we try to stage these patients with contrast-enhanced CT scans. And at our institution, all our studies for ovarian cancer are done with a dual energy CT scan, which really helps us also identify implants along the diaphragm. So with the imaging study, we can look at all the critical areas which require debulking or taking out the tumor. And we create reports which will tell exactly where the implants are, what kind of cancer it is, or where the cancer is, what it is involving. And based on the reporting, the surgeon decides whether the patient needs to get in neoadjuvant treatment, or they need to go get upfront surgery or postoperative chemotherapy. So based on all these factors in a multidisciplinary conference, we decide what to do. Now, sometimes a patient may have an ovarian mass and we can't really characterize it on a CT scan because it just looks solid. It may just not look like it's cancer. And we would advocate doing an MRI on those patients. MRI has better spatial resolution and better contrast resolution, and it will tell us what the mass looks like. Now, MRI has the ability to differentiate tissues. It can tell you differences in blood, mucin, or it can also tell you whether it is soft tissue or it has fibrous tissue within it. So it will help you understand the characteristics of the tumor much better. And it will also help us differentiate a benign tumor from a malignant tumor. And so in those cases which are borderline, like where we cannot really understand whether it's cancer or not, we advocate doing an MRI in those patients. And if the patient has disease all over the place, sometimes in different institutions or different cancer centers, they will also advocate doing a PET CT. But usually PET CT is not a must, but sometimes it's done in order to stage the patient completely.
Thank you. And so in terms of, we talked about you. First of all, thank you for explaining the whole process here. So in terms of survivorship, though, when a patient, let's say her treatment is finished, right, completed, and so she embarks on that survivorship phase, but, there's this periodic scans that they need to come back to, which leads to the scanxiety that we all know that word, right? So walk us through that a little bit in terms of what you are seeing in terms of, what are you looking for when the patient comes back for those kinds of follow-up, scans? What is it that you're looking for, and what is it that, that raises a red flag versus not?
Right. So what happens is the patient gets a debulking surgery. The surgeon is very happy with the surgery. There's no residual disease. They may or may not get neoadjuvant treatment following the surgery. And then the patient comes to us to get the imaging study, we basically do again a triple phase contrast enhanced CT scan. And what we are looking for is small nodules, because even the small nodules can grow later and become large masses, which may or may not be resectable in the future. Currently, I think MD Anderson is trying to go into doing second look surgeries. So we try to get to a point where we can identify every nodules. Now, it's different for different kinds of cancers, as for the epithelial neoplasms, which are the most common ones, surgery may or may not be done, the second look surgery. But for low-grade tumors, usually if it's only a solitary nodule, especially in granulosa cell tumors, the surgeon may go in and try to debulk these lesions, and they may do multiple surgeries trying to remove them, because these tumors are pretty indolent, and the survival is really high. The percent of people who survive with the low grades is really great. And especially for granulosa cell tumors, we'll try to find the smallest lesion, and point them out for the surgeons to go and pluck them out, because they're easy to remove. And we work closely with the surgeons before the surgery. We tell them where exactly the tumor nodules are based on the imaging findings. And this really helps the surgeon to go and take out the tumor in the entirety, and obviously helps with the improved survival of the patient. And usually the CT scans are done 3 monthly after the surgery, and they also do a CA-125 after that. Most of the time, as the CA-125 is increases, we will see something on imaging, but sometimes, CA-125 is not that specific, even though it's very sensitive, So if there's some peritoneal irritation, if there's some peritoneal fluid, the CA-125 may increase. And there have been several studies which tell us that when you do not see disease on CT scan, but even if you have elevated CA-125, a patient shouldn't be treated. So we try our best as radiologists to find the smallest lesion so that that patient can be treated optimally. Yeah. So while we're looking at the imaging studies, we take the whole picture of the patient. We try to figure out what pathology the tumor is, what was the surgical resection status, were they able to take out the entire tumor or not, where the tumor was, has there any tumor left behind, and the grade of the tumor, obviously the low grades versus the high grades. And also on imaging, depending upon the low grade versus high grades, the low grade tumors will have calcifications within them. So we've taught our radiology colleagues and and our students, to look for these tiny calcifications, because the appearance of these calcification means that the tumor is back, especially in low-grade serous tumors. And so we have a search pattern. We try to make sure that we point out the tiniest nodule we see on the contrast enhanced CT scan when we are looking at these imaging studies.
Wonderful. I heard you mention the word pathology, so I'm just going to go back to that for a second. So because I feel like, in the whole treatment process for ovarian cancer, right, the surgery, the chemo, the way I see it is the front line treatment, but there's so much that goes on in the background, like the radiology, like pathology, all these things are equally important, even though it is not like in the front-facing treatment pattern. So how closely do you work with the pathology department in patient care, and just anything that you could share on the importance of pathology and radiology working together for personalized treatment for patients?
Right, so we work really closely. We also have a RadPath conference going on at MD Anderson for teaching purposes, as well as during our multidisciplinary conferences. Each patient who is presented, they have their pathology reviewed, their radiology reviewed, and their clinical status. And sometimes, the pathologist will say radiology correlation is recommended, because they may see something within a bladder, where basically it could tell them that it's an estrogen positive tumor, but I mean, the tumor is not really a bladder cancer. It could be an ovarian cancer. So they will say, please correlate with imaging findings. So we go ahead and discuss with each other. We look at the imaging findings and try to figure it out. So sometimes, there could be para-ovarian masses versus ovarian masses. And in that case, you really don't want to remove the entire ovary. You could just remove the para-ovarian mass, specifically when these are not cancers, like you have endometriosis, where there's a large mass adjacent to the ovary. And it looks like cancer on the imaging, but the pathologist only has a portion of it, which says it could be endometriosis. And then we discuss everything together and correlate it. And with the surgeons together, a decision is made how to operate the patient, how to go about the surgery, whether they need to do laparoscopically or they need to make it an open surgery, depending upon where the entire disease is present. And so we work very, very closely with the pathologist.
Thank you for sharing that, because it's so important for the patients, our overcomers, and the family members to understand, how this multidisciplinary team actually work in bringing sure that the patient and the overcomer is treated optimally and in the best way. So thank you for sharing that. So, how are ovarian cancers classified and staged from a radiology standpoint? If you could tell us, and if there are any new classifications that you want to share with us.
So on imaging, most of the time, there may be a mass or there may not be a mass, but on imaging, if you do a cystic mass, it's usually a epithelial tumor. And we also look at the imaging findings, whether it has vascularity. That means if it has blood flow to it, or whether there are nodules within a cystic mass. If there are many more nodules, especially in imaging, we say more than 4 nodules, and it's a more aggressive tumor. If it's less than 4 nodules within a cystic mass, it is a less aggressive tumor, and vice versa. If it's a totally solid mass, it may be very difficult for us to tell whether it's an epithelial neoplasm or a non-epithelial neoplasm. And at that juncture, we ask to get an MRI. And then we also correlate with the tumor markers. I mean, we just talked about CA125, but there are other tumor markers at inhibin and things like that. So we correlate it with the other tumor markers. Even estrogen is one of the tumor markers, especially in granulosa cell tumors, the women may have increased estrogen production. So we factor into all the findings when we are looking at an imaging study, and we can give a diagnosis. If it's a very solid mass and has internal hemorrhage within it, like blood products, it could be a endometrioma turned into malignancy, or if it has a ground glass appearance or a stained glass appearance, what we call on imaging, it could be a mucinous tumor arising from the ovary. So there are certain patterns which we look for on imaging findings that will tell us what the tumor is, and is it more towards a benign etiology or more towards a malignant etiology. So in around 2013, we worked with our surgeons for staging these patients and optimally making sure that they can do optimal debulking. So it was a quality improvement study. We worked over 4 years, 3.5 to 4 years, and we came up with a radiology template. And what we did was whatever we saw in radiology, they would go in and look at it surgically and correlate. And based on this correlation, we created this template. And currently it's being used all over the country. And it's not only important, like we do a CT scan, but it has to be optimized to look for ovarian cancer. For example, I said we do triple contrast. So it's very important to get an optimal imaging study to make sure that all the disease is caught, and then the surgeons can go in and take it out.
Okay, thank you. So, so as we understand, imaging is integral in various aspects, and like we talked about in assessing ovarian cancer. So it is not only used as a diagnostic tool, but it also, as you have alluded in your conversations, that it can be a major element in determination in triaging patients to personalized treatments, right? So what is the role of radiology in this case, where patients are triaged into a particular, a specific kind of treatment based on their histologies, and what can you share with us on that?
Okay, so based on imaging, on what we see, so if the tumor is confined to one ovary, then it's stage 1 disease. When it's confined to both ovaries, it's stage 2 disease. Sorry, 1B disease. And when it's involving the pelvic organs, it is stage 2A. And when it goes into the pelvis and beyond, it's stage 3 disease. Now, currently, the lymph nodes have been incorporated in the staging system, and they cannot be seen on physical exam, obviously, and they cannot be seen on ultrasound. So CT has been the cornerstone or the modality of choice to look for these lymph nodes, and based on where the lymph nodes are, below the pelvis or above the pelvis, the surgeon may decide whether to extend the laparotomy scar to the umbilicus or over the umbilicus. And also based on what we see under the diaphragm, I mean, if we do see like an infiltrative plaque, like infiltrative disease along the diaphragm, the surgeons will go in and extend their laparotomy scar all the way up to the xiphoid process and try to get the tumor out. Now, also based on the size of the implants along the diaphragm, if these implants are greater than 2 centimeters in size, the clinician or the surgeon will decide to do neoadjuvant therapy in those cases. If the tumor is involving the stomach or is involving the porta hepatis area or infiltrating into the liver, then they will decide to do the neoadjuvant treatment rather than going upfront resection. Now, on imaging, we can tell whether there is intraparenchymal disease, that means inside the liver or on the surface. Now, when it's inside the liver, they will do neoadjuvant treatment. If it's just on the surface, which is resectable, they'll go ahead and resect it. Now, there are other things which they look for, involvement of the sigmoid colon. I mean, if we do say that sigmoid colon is involved, our GYN surgeons may involve GI surgery to come in and do bowel resection. So there are different aspects, I mean, which are used during a multidisciplinary conference based on imaging findings, and a decision is made how to operate the patient. So this is considered personalized care, based on what we see on the imaging. Absolutely. The surgeon will invite a different team. They would invite GI surgeons, or they may only do it by themselves. Sometimes they also involve plastics if the tumor is involving the anterior abdominal wall. And if that's the only tumor, they will resect that out and it's reconstructed by plastics. So there are different aspects which go into this. Recently, we've been using 3D printing for assessing the disease and also helping the surgeons understand what the disease is. And this has been specifically used for pelvic exonerations, like in advanced diseases where the patient will want to have surgical removal of the tumor, especially like when the ovarian masses or the low-grade tumors are infiltrating into the vagina, and they would like to do a pelvic exoneration, and that's the only site of disease in that patient. So we've been helping them visualize the tumor with 3D printing, and it's become really popular at MD Anderson for other surgeries as well as for ovarian cancer surgery.
And thank you for walking us through this, because it was just fascinating to hear you talk about all the background information and all the background activities that go on before the surgeon actually decides on what type of surgery is best for the overcomer in question. So we often do not get these kinds of perspectives. So thank you for sharing that with us. Much appreciated. So, just continuing our discussion on this, from a radiological perspective, it seems pivotal to understand the subtypes of ovarian cancer, right? And so, because they may manifest with different and unique characteristics. So how are these identified on imaging and then reported to the physicians to maximize treatment possibilities for patients? Because as I understand that ovarian can be different types, right? I mean, ovarian is just not low grade and high grade, but even within that, there are many subtypes ovarian cancer, and the more accurate the diagnosis, the upfront diagnosis, the more accurate the treatment pattern. And so this is where the radiology comes in, and at the onset of the diagnosis, where I feel that it's a very critical role to, identify and qualify that particular tumor in its appropriate category. So tell us a little bit about that.
So different kinds of tumors have different appearances, and we discussed earlier the low grades versus the high grades, the calcifications versus the non-calcifications, presence of hemorrhage on imaging, which will tell you whether it's a certain type of a tumor, like a granulosa cell tumor, or it has some other manifestations, like you can also get a certainly Leydig cell tumor within the ovary. It's pretty rare, but you can get that. So actually, as a radiologist, you cannot diagnose the type of the tumor based on the imaging pattern, but you have to take into account the patient's age, the tumor markers, what the patient is manifesting with. I mean, some patients present with hirsutism, some patients have increased menstrual bleeding, things like that. And so you take into account everything. You also have to look into the history of a patient having endometriosis, because endometriosis can also lead to cancer and it could be attached to the ovary. Right. So you have to take into account all the findings together to tell the surgeon where the tumor is and what the tumor is. And when you say it's only confined to the ovary, or it's probably a fibrous tumor, like a fibrothecoma, most likely a benign tumor, not a cancer, they will go in and they will remove it laparoscopically. So that's how we help them, whether to tell them it's not exactly the pathology we can tell because we are radiologists. There are certain characteristics which can help us determine that this could be a tumor, which is a granulosa cell tumor or a theca cell tumor, or whether it's a fibrothecoma. But actually, we cannot really tell the cellular pathology. Mm-hmm. Even though, I mean, there may be claims in the radiology literature, yes, we can tell you like this is this cancer and that cancer, or anything like that. It's very difficult. If you see thousands of cases over the years, there's always an overlap of imaging findings. So we cannot be pathologists. We are just radiologists. We can tell you where the tumor is, how big the tumor is, and what it's involving for taking the patient to surgery and providing personalized care in these patients.
Yeah. And I guess this is where the friendship between the radiology and the pathology comes into the picture, that where you hand the baton over to them and they then analyze the tumors a little bit more before the surgery and the chemotherapy team comes into the picture for the overall treatment of the overcomer. So thank you for walking us through that. So you've talked about the fact that in cases of ultrasounds, it is very, very important that it is done correctly and it's done accurately so that the diagnosis is correct. So what kind of collaborations do you think is needed with the surgeons and others in the healthcare team to not only just diagnose the correct type of appropriate type of tumor but just in the overall, treatment of the patient? I mean, what goes on in the background? You've mentioned a few things, but just in an ideal world where every department is working optimally together, how do you see this orchestrating?
So we do have a multidisciplinary team at MD Anderson. So we have a team of radiologists who help the surgeons with reading the gynecological cases. And at some point in time, we had a great collaboration where we would be sitting in the clinic. The surgeon would be seeing the patient, and then the surgeon comes in with questions, like my patient wants to know exactly where the tumor is. The patient walks in, and as radiologists, we show them the whole imaging study, show them where the tumor is. The patient understands and knows what's going to be done for them. And that would be the ideal world where every patient gets to see the radiologist, surgeon, look at the imaging findings and be comfortable with what's going to happen to them in the future. So we used to do that, but COVID has brought in some constraints to it, and it's been very difficult since COVID started. But in an ideal world, I mean, that's what should be happening, where everybody should get together and look at the studies, imaging findings, the patient's clinical factors, and the patient should be treated upfront. And sometimes it's very critical that the surgeon understands like what we're talking about, but because our language is not similar to their language, they do the surgeries, radiologists do their reports, and I think we need to have standardization, common language between the surgeons. Like when we say, yes, there's tumor here, in a certain location, it should be understood by the surgeon that it is there in that location. And I think we've come really far. We've standardized our language for our surgeons, and MD Anderson is moving to standardizing all the reporting so that everybody understands what's going on in a given patient for treatment planning.
And for mentioning the patient in this whole picture, because I feel like that is the most critical part. Because to your point, I don't feel that the patients have much time or exposure to the radiologists in any institution, not just Anderson, any institution. So that is probably an interjection point where our overcomers may have so many questions about their imaging. And so it would be so wonderful if there was some collaboration or interaction with the radiology department in whichever institution they're being treated at, so that overcomers and their family members have that opportunity to speak with the radiology team lead or the team in general to ask more educated, informed questions. So I agree with you. In an ideal world, the overcomer would be at the center of all these discussions. So thank you for mentioning that. So I was reading recently about this glowing tumor imaging and synoptic report. And so, and there seems to be certain new drugs that are approved by the FDA to help identify the ovarian tumors in imaging. So what can you talk to us about those things, and what else is in the horizon when it comes to ovarian cancer screening and imaging?
So the glowing tumor is a fluorescent dye, which is injected in a patient. And what it does is lights up. Yeah. So even like a couple of millimeter tumors will light up, and the surgeon can easily see them. Obviously, the surgeon is in the patient's belly, but sometimes there may be areas which may be missed or may mislooked or overlooked because they can't get to it. This fluorescent dye will make them more apparent, and then the clinician or the surgeon can visualize these tumors very well. So I haven't heard about it at MD Anderson, but I also read it. It's at UPenn, like they've been looking at it. And then the synoptic reporting, that's the same thing which we talked about, was the template which we created. And so when a general radiologist does a report, there was a recent study which talked about the synoptic reporting versus a general report. So they said when a general report is created by a radiologist, it takes about 20 minutes, but the synoptic report takes about an hour to do, because you have to look at every crevice of the imaging study, every crevice of the organ, and come up with a diagnosis, and look at every inch of that image, be very meticulous to make sure that you get the correct diagnosis. I mean, I did get an email from a patient a couple of months ago. They said, what is the best? I don't know her, but she said, she just wrote to me. Somehow she got my email. She says, what's the best study for ovarian cancer? I had an imaging study. They said there was no disease. My surgeon went in, and my whole abdomen and pelvis had disease everywhere. So it's, as I said initially, it's really important to get an appropriate imaging study, the correct imaging study with contrast available and the latest technology which we have. So yes, there are many things which are happening in this world today. There are many new advances, and we should be able to incorporate them into our daily practice. Now, there have been certain imaging agents that have been approved. I mean, the fluorescent one is, as we talked about it right now. Then there is the PSMA, which accumulates in ovarian tumors. It's been used for research purposes. It's not been really used clinically as of yet. And then we have the estrogen PET, which tags the estrogen positive tumors. It's been used in breast cancer, but it probably will be approved for ovarian and endometrial cancer too, because they're estrogen positive, the low-grade tumors usually. And so that's a promising tool. Currently, there are several ongoing studies for detection of early stage ovarian cancer with microbubbles, which are injected during ultrasound, and the ovaries are imaged. So if the microbubbles accumulate in the ovary, then there's a chance that that person will develop cancer in that ovary. I mean, these are latest technologies, but again, as I said, ultrasound is very operator dependent. So if you do not have a good ultrasonographer, the images are not going to be adequate and you're not going to see it. The latest one, which we are using or we are hoping to use to detect early cancer, is hyperpolarized carbon. I mean, I have ongoing trial. And what we are planning on doing is using the hyperpolarized carbon in patients who have no history of ovarian cancer, patients who have high risk of ovarian malignancy and ovarian cancer itself. So it's a pilot study trying to figure out whether this is really going to help in detecting the early disease because it measures the lactate and pyruvate peaks within the ovaries themselves and the tumors. And hopefully it will be able to diagnose patients in their early stages of disease. And so the hyperpolarized carbon is injected in a patient, and then we image it with an MRI machine. So it's an MRI study. And hopefully we get good results, and we are able to help all these women who are going to develop ovarian cancer in the future.
So you piqued my interest with what you just said. Between the microbubbles and the other trial that you just mentioned. So I was going to this was my great segue into my next question, which is going to be, tell us about the trials that you're running for ovarian cancer and imaging. So in terms of, you said women who don't have ovarian cancer and who are at high risk for ovarian cancer, right? You mentioned that. So we are all about prevention. We are all about, awareness. So are these women who carry mutation, or are these women who have family history or both? Can you qualify the criteria a little more in a little more detail for us?
Right. So they're all patients with high risk, the breast ovarian cancer syndrome, patients who have the BRCA mutations, patients who have Lynch syndrome. They can also develop ovarian cancer. So all those patients are eligible for the study, and patients who are going to be used as control are the patients who do not have any history of any malignancy will be used as control in the study. And obviously, we would like to see what the ovarian cancer looks like on the hyperpolarized carbon, because that's how it's going to do. If whatever we find with the cancer looks the same in a patient who has positive BRCA, mutation, then there's a possibility that this patient may develop cancer, and a normal ovary may not have the same changes as that of the BRCA patient or Lynch syndrome patients. So that's the idea behind it. Hopefully we are successful in figuring this out. And the microbubbles have been used in Canada a lot. They've done several research studies about it. And we have been using it at our institution, but it's used for renal cancer. We haven't been using it for ovarian cancer as such for early detection. But I think it's a promising tool because hypervascularity is a sign of having malignancy by using the microbubbles. And it's possible that it's able to detect cancer in the early stages. But there haven't been any longitudinal studies or large cohort studies to tell us whether this is beneficial or not.
Yeah. So my thought as you were talking is also that, for this almost sounds like that these women will need to be followed for several number of years to see whether or not they eventually develop ovarian cancer. Because to me, not all BRCA carriers will develop ovarian cancer. Some may at all, right? Through lifetime. So when you are following these patients, it is going to be a long-term study. So when is it supposed to read out? What is do you know?
So it's going to start, it's almost started this year, and it's going to take about 5 years because we have a long-term follow-up in these patients. And so it's going to take 5 years. And we'll have some results at the end of 5 years. Also, we just completed a study on PET-MR, looking at the disease status in these patients, like trying to find the smallest lesion within the abdomen and pelvis to be resected. And we just completed this study. We're looking at the results, and it seems pretty promising, because most of the times when we do the contrast enhanced CT scan, and we may or may not find these small lymph nodes within the chest, abdomen, pelvis, whereas on a PET MR, they may light up and they may have a different marker on the imaging study, like a diffusion sequence, where they're dark and metastatic. And that could be a game changer, changing the patient from getting neoadjuvant treatment to just upfront surgery. So things like that. I mean, and the PET-MR study seems to be very promising. We've looked at our results and we'll be publishing it soon.
Wonderful. Thank you for sharing all this wonderful information. We look forward to more information as they come out because, as you said, that, prevention is of particular interest to the entire community, right? So if there are effective studies which are better than CA-125, right now that is the only, and that is also not, as we know, that's not the gold standard of detection. That could be for the CA-125. So anything that comes up, comes out in the next few years when it comes to screening or detection of ovarian cancer early, we are all for it. I know the whole community will back us on that. So thank you for sharing all that. So I know we had a really fascinating discussion on just understanding the radiology and the background of ovarian cancer diagnosis, what happens after the diagnosis, how we treat the patients, how we triage the patients. So what have I missed asking you that you would like to share with our audience?
So I would just want to say one more thing, that I really believe that getting a optimal staging study in the very beginning is very important. And if you do have cancer, go to a tertiary care center where they only operate on cancer patients so that you can get optimal surgical debulking where there's no residual disease left behind, and that could improve their survival. That's really important, I think, and that's the algorithm we should be following. And then I believe that every patient should get optimized care, a great imaging study so that their disease can be found.
Absolutely. And like you said, at the point of diagnosis where, we are learning more about your disease, we are learning more about the type of cancer, ovarian cancer we have, what is the tumor histology, etc. That is so important, the first step, because that determines the rest of the life cycle of treatment. So it's so important to do that well and to go to a center where they're more experienced and they're doing these things at the national, international, global level. So thank you. So great discussion, Dr. Bhosale. So in parting, how would you share your inspiration and your parting message for our overcomers listening? What would you share?
I believe our overcomers are amazing. They're resilient. They've gone through a journey which has almost transformed them, and it's transformed their family members. They need to know that they're not alone in this war. We all are with them, and together we can overcome.
I love that. Thank you, Dr. Bhosale. And this was a great discussion. Thank you for sharing your pearls of wisdom and your insights. And this was, like I said, this is a very fascinating conversation in the sense we got to see the background of how ovarian cancer is diagnosed and managed from a radiology perspective. So thank you for sharing your wisdom with us. And overcomers, hope this was beneficial for you. As I always say, we always learn from this expert so much. And we had this unique perspective shared with us today by Dr. Bhosale on the radiology of ovarian cancer. So please share this information far and wide with anyone who may benefit from all these great insights that she shared with us today. And we will be back with the next episode of Connect Over Coffee very soon. Until then, you keep overcoming. Thank you and bye.